COVID-19 Military Support Initiative was launched by the Association of Defense Communities, Blue Star Families, and participants of the White Oak Collaborative. It's a comprehensive resource for communities, states, and military families during this pandemic, with virtual events, daily news updates, and ongoing pain points polling. The Association of Defense Communities is a leader in supporting the resilience of communities and states that support America's military. Blue Star Families is a national nonprofit supporting active duty, National Guard, Reserve, veterans, and their families while strengthening local communities. The initiative is presented by Booz Allen Hamilton, with significant support from USAA. Other sponsors include the Bristol-Myers Squibb Foundation, the Association of Military Banks of America, the Military Housing Association, Hunt Companies, J.P. Morgan Chase & Company, and First Command Financial. And now, today's CMSI virtual event.
Welcome. Thank you all for joining us this afternoon. My name is Kathy Roth-Duquet, and I'm the CEO and co-founder of Blue Star Families. I'm happy to welcome you all to this event. Today's town hall is healthcare for military families during COVID-19. Before we welcome today's guests, I'd like to talk about our pain points poll data. As many of you know, CMSI has been conducting a pain points poll to identify the challenges or pain points our military, veteran, National Guard, Reserve, and civilian families have been facing as a result of this pandemic. We had 822 respondents in week 7, bringing us to a total of over 6,000 respondents. We saw a big increase in National Guard respondents as a proportion of the sample, and we thank our National Guard partners for that. Our most acute pain points, 38% of service member respondents are at least somewhat concerned about the impact COVID-19 restrictions will have on their ability to receive a fair evaluation in their current position. This matters because canceled training events and social distancing requirements have impacted many service members in rated positions. We're bringing this concern to the attention of OSD, and we'll be addressing it in future town halls. 8% of respondents with current PCS orders remain displaced but have housing, and 5% do not currently have housing. We also have some interesting findings about the differences between male and female respondents. I urge you to look at these results at more depth on our CMSI website. I'd like to make a spotlight, though, on military family health and wellness, since that's the topic of our town hall today. We're seeing that on average, military families have not seen an improvement in their ability to access health care for non-COVID related reasons, or in their ability to maintain continuity of care for mental health and behavioral health challenges. Week 7 saw the lowest percentage yet of respondents reporting that their family cannot obtain prescription medicine as a result of the crisis, so that's good news. It's encouraging, but we'll keep an eye on this issue. So now on to our town hall. First, how to ask questions. We want as many of you as possible to ask questions. Do so in the chat box on your screen. We'll get those questions to our panelists, and any we don't answer during this panel, we'll answer offline, and we'll post those responses for you on our website. It's now my privilege to introduce our opening speaker, Colonel Silverman, Chief of Staff of the Defense Health Agency. With over 28 years of experience working in the federal sector and in healthcare industry, Colonel Sherry Silverman is a transformation leader. She serves as the Chief of Staff of the Defense Health Agency and is the Principal Advisor to the DHA Director on all military health system matters, including fortifying the relationship with Health Affairs, the Joint Staff Surgeon, and the Service Medical Departments. We are thrilled to have you join us today.
Hi, good afternoon, everyone. So I want to thank the National Military Family Association, the Association of Defense Communities, and Blue Star Families for hosting this virtual town hall and for allowing me to say a few words today. And I like the point that you brought up some pain points right off the bat, and hopefully we can sort of alleviate maybe some of those healthcare concerns, because I know we're all under some constraints today with healthcare, accessing our healthcare needs. And as a former military treatment facility commander and a licensed physical therapist, I understand the value of partnering and communicating with our customers. During this pandemic, it is even more important now than ever to keep our military families informed on how to access healthcare and other critical services, many of which I know you've already addressed in some of these sessions, and hopefully we can address those others today. So my family and I even had to adapt to the change in healthcare way it's administered today, especially under COVID. My daughter had her 12-year-old well child appointment before we sort of delayed the elective surgery. She did that via phone. We wouldn't have done that several months beforehand. I even had a specialty care appointment that was done over TRICARE Online. So it was very interesting trying to take pictures and upload those for my specialty visit. And there was not, I experienced technical issues on my end, much as the provider did on the clinic end. So I appreciate that you all are patient with us as we adapt and overcome some of these issues. And we address these on a whole different level virtually versus our normal face-to-face visits. And the last thing, even in our network and for dental, my son is wearing braces, and because of all the delay in his accessing his routine care for his braces, they actually overcorrected him. And now when Virginia now is allowing elective surgery, we find that he's going to have to wear braces an extra 30 days. It's minor, but again, those all impact us and our family members as we go forward in this environment. But I can assure you that the Defense Health Agency is in full support of the Secretary of Defense's 3 priorities during COVID. 1, protecting the force. 2, maintaining readiness. And 3, supporting the whole of government response. And today I hope you'll see how we as an agency has worked hard to rapidly adapt to these unique healthcare needs of the military community and our families. We think it's very important to us. And so today you're going to hear from 3 of our top experts on some of the actions that we've taken. Like other healthcare systems, we've had to restrict some services like elective surgery and pharmacy access, but we have taken aggressive action to mitigate the impact on you, our beneficiaries, by expanding telehealth, promoting mail order pharmacy, and these are just to name a few of the measures that we want to ensure that you have the access to care for your healthcare needs. However, what I'd like to do today is give you a brief update on some of the military health system reforms that we have underway. First of all, the military treatment facility transition. Many of you know that from the NDAA 17, but you may have heard that the Deputy Secretary of Defense, David Norquist, recently approved a 90-day pause in these efforts to transition military treatment facilities to the DHA to allow the military services and DHA to focus on the COVID response. Now, what does that mean for you? That means this pause is going to go through 1 July. Our 45-day assessment is coming up at the 17 May transition point. And we're going to make an assessment. Do we need to extend that 90 days? Are we on target to back to normal activities after that 90 days? And so what's happening is that the service medical organizations are required to extend their direct support to the DHA for a period maybe beyond that September 30th, 2020 target date to have completion. And that may add those days, the number of days that we've got paused, may be tacked on that other end of that goal line. And the decision to put on the transition wasn't taken lightly, but I think it was really important for us to focus our efforts, because I know 90% of my time, it's eased up a little bit, shifted completely to COVID. So I imagine that's the same for all of our service agents, our providers in the market. So we wanted to take one thing off their plate so they can focus on the response to you. But what that does is it puts the transition on hold for the next 5 markets, which is Tidewater, San Antonio, Colorado Springs, Puget Sound, and Hawaii. And as soon as that we can make it practical, we'll start that transition implementation back up again. The other effort you may be interested in is the restructuring and realignment of military medical treatment facilities. The restructuring and realignment of MTFs under the fiscal year 2017 NDAA, section 703. Really, when that came out, it was never intended to be an immediate after report as soon as that report to Congress was published. It was going to be deliberate, measured steps for individual assessments of each of those MTFs that were going to be impacted by this study. These plans were going to be condition-based, and they were going to involve collaboration with the DHA staff MTF and installation leadership, as well as the TRICARE network partners, to assess each of these MTFs and see what is feasible for you as our beneficiaries. And once those plans have been developed, then that's going to take 3 to 5 years to fully implement. So you can see that's going to take some time. And right now, it remains to be seen what impact the COVID-19 response efforts will have on the timeline for MTF restructuring and realignment. Lastly, military medical billet reductions. I know this has been in the news quite a bit lately, but the Section 719 of the FY20 NDAA set forth some additional requirements that the department must meet prior to realigning or reducing military medical end strength. And so the department's still working through these requirements, and no final decisions have been made. And again, we'll see how COVID-19 will impact those decisions, and we'll make sure that to keep you informed as soon as any decisions are made. But I thank you again. I really enjoy the opportunity to be here for you today and keep you up to date on the issues that are going on at DHA that may be relevant to you. But this is your healthcare system and your health plan, and we need your feedback to make sure that we're getting things right. And especially in this time of pandemic-driven social distancing, which has driven this virtual town hall today. So I wish we could have all been in here in person, and someday we'll get there. But in the meantime, thank you for allowing me to speak today.
Thank you so much, Colonel, for being with us today and starting off this important conversation. So much has changed for all of us as we adjust to COVID-19. We appreciate your team's effort to adjust and make sure service members and their families continue to have access to the important benefits you provide. It means a lot to have you so accessible to us today. And I'm excited to say we already have some great questions coming in. I'm delighted now to welcome Ash Vazirani, Executive Director and Chief Executive Officer for the National Military Family Association, who will be moderating our discussion. NMFA has been such a wonderful partner in addressing the needs of military families throughout this COVID era. We appreciate their support with this virtual event today. Ash, I'll stay on with you to help field our audience questions, but I'll turn it over to you now to introduce our panel participants.
Kathy, thank you very much, and thanks to you and the folks at ADC for continuing to lead this initiative. I'd like now to introduce our panel of experts from the Defense Health Agency. We have Captain Edward Simmer, who's the Chief Medical Officer of the TRICARE Health Plan, Ms. Regina Julian, who's the Chief of the Healthcare Optimization Division, and Colonel Mark Gamelin, the Acting Chief of the Pharmacy Operations Division. Captain Simmer, Ms. Julian, Colonel Gamelin, thank you very much for joining us today.
Thank you for having me.
Appreciate it. So we have a lot of questions, as Kathy indicated, coming in from the audience, but maybe we'll just jump right in, and maybe I'll just start with a question to you, Captain Simmer, and to you, Ms. Julian. The Department of Defense has had to rapidly adjust to meet the unique needs of the defense community during the COVID crisis. One of the greatest concerns military families have expressed is continued access to health care. Can you give us a sense of the changes that the Defense Health Agency has made to ensure that military families can continue to access health care when and where they need it?
Sure, I'd be happy to. So I think from the purchase care side, from the TRICARE side, we've made a number of changes to try to ensure that people can access health care as they need it, where and when they need it, without having to expose themselves unnecessarily. So a number of things we've done. Just effective today, we've made several changes to the benefits. We now cover audio only telehealth. We also cover the care when it's across state lines. In the past, you had to have a license both in the state where the provider was located and also where the patient was. Now we've relaxed that so that many states have relaxed those rules, and we now follow the state laws so that if a state says, you can have a temporary license, you don't need a license to see a patient if you have a license in the state you're at. We now respect all of that too. We've also eliminated the co-pays and cost shares for telehealth visits to encourage folks to use telehealth during this crisis. And we're hopeful that all of these changes, which, as I said, just took effect today, will make a significant difference. We're also working very closely with our direct care partners Ms. Julian and her teams to make sure that if a direct care facility has to reduce their capacity, we have the purchase care capacity to fill that in very quickly and make sure that we can continue to provide care where and when it's needed to all of our beneficiaries.
Captain Simmer, thank you. Regina, Ms. Julian, anything you'd add to that?
So I'll add, of course, all the care we provide is a partnership between direct purchase care. Our patients go back and forth, and we want to make sure it's as integrated as possible. But when this kind of kicked off at the beginning of March, our only solution was to tell you to call the nurse advice line. And that led to some really long wait times that are now down to 3 seconds consistently. But what we found is patients had a lot of anxiety and questions. They didn't have COVID, they just were afraid, and that's totally understandable. So our strategy was based on industry best practices. The first thing we wanted to do was alleviate patient anxiety. Second, make sure we could get good evidence-based advice to our patients. And then third, make sure that they got care in a way that protected them and our medical staff from exposure. So we developed a great educational series of tools on TRICARE.mil, and the great thing about that is we update them constantly, and all the MTFs have got that same link to the TRICARE.mil information on their web pages. We sent out guidance on the 17th of March and ensured that this got out to our patients via secure messaging, on recordings on nurse advice line, all the different ways we could reach patients. And in fact, we saw that our secure messaging traffic is up over 1,000% of us trying to get word out to our patients so they knew what to expect and that they could, more importantly, still get care. So let me get to the care part. First, we want to be able to provide not only nurse advice line, but our own nurses, your nurses that you know, giving you advice on COVID that's evidence-based. So it's not based on their impression, but based on what the medical evidence, the most updated information. And it could be about COVID, or it could be about something non-COVID related, because all your medical needs are important to us. Then we rapidly changed our templates to make sure we could do virtual appointments first. So if the provider needed to see you face-to-face, we'd have a deliberate way to have you come in to protect you and our staff through entry control points. And right now, we have consistently been filling only about 50% of our appointments. I don't think that means that our patient demand has really dropped that much. I just think people may be delaying some care. So we're now trying to reach out and proactively look at patients that may have complex issues or cancer screening needs or other screening needs, and ask them to come back in a way that we can be sure of their safety. But one thing I do want to stress is during this pandemic, like all healthcare systems, we continued providing medically necessary care that could not safely be delayed. And we were able to find out that there is a lot that we could do, as Colonel Silverman said, using virtual health. So going forward, we plan to expand that even more. It's convenient for our patients, it's convenient for our staff, but we want to reinforce to you that if you have a medical need that is not COVID related, we have plenty of access right now. So call the nurse advice line, send your team a secure message. They'll answer within 24 hours. You can now book virtual appointments online for any reason on TOL. And then finally, you can call your appointment line and we'll make sure that you get an appointment. Again, we may have it be virtual first, especially in primary care. And if we can't address it, such as childhood immunizations, we have not figured out a way to do that over the phone or on camera, we will bring you in because we're committed to your healthcare needs.
That's great. Thank you very much. Kathy, do we have any questions that have come in that we want to get to? Kathy, I think your line is, thank you.
Thank you. During this pandemic, is there an exception for enrolling newborns within 90 days for a birth in DEERS? Some ID offices have been closed.
I don't know the exact rules of engagement, but I know that we have recently put out a policy and worked with DEERS to have a leeway for people who aren't able to get their ID card. So I am certain that they're still able to get care, but we'll have to follow up with Ash and let you know later. But I do know that a policy went through, and I think it included newborns.
Great. We'll get that information out.
Thank you.
And Are there any updates on the autism therapy? There were concerns about being able to have ABA therapy delivered through telehealth. We had a question about if that's possible to do now, or any movement in that.
So we do cover family guidance and family training from applied behavior analysis providers who are the folks who commonly treat children with autism. That's an unlimited benefit by telehealth that we've added for the duration of the crisis. And really our intent there is to ensure that families can continue to get support from their autism providers while the in-person services may not be possible, because often those services are provided in the home, and it's difficult for providers to get into the home right now, of course, with the travel restrictions and concerns about exposure. By allowing those providers to provide unlimited support to the family members, the parents usually, they can then work with the child and help keep the child's treatment goals moving forward until we can get back to in-person services.
Captain Zimmer, we've had families ask us for direct support for those autistic children and not just training for the parents, because many parents feel they're not able to do that well. Is there any response to that question and that concern?
Well, I'd point out, first of all, that the child can be present during those sessions with the provider and the parent. And so they can be working directly with the child, too, during those times and teaching the parent how to do that all at the same time. There are certain components to direct in-person applied behavior analysis services that really have to be done in person, because you're giving the child a reward, food or something. And you're also giving, tracking their behavior very closely. It's very difficult to do that over a video connection. So we're not covering direct, person to child services like that. But because the child can be present during the parent services, I think we can still get much of that and maintain progress with the treatment until we can get back to in-person services, which is really the ideal.
Thank you.
Thank you, Captain Zimmer. Just you mentioned earlier about telehealth, and we were pleased to see the expansion of the telehealth capabilities. And then today's announcement around telemedicine, you mentioned with audio only. Could you expand a little bit more on those capabilities and the coverage, and what these changes mean for families?
Sure, I'd be happy to. So I think a couple of big changes. One, of course, is the elimination of the co-pays and cost shares with telehealth visits. That encourages families to use that service and will also help them hopefully save some money. And then the audio only is very helpful because not every family, not every provider can have a secure video link. So by authorizing audio only visits, that will increase access to care, make sure families can get the care they need when and where they need it. We've always covered telehealth, at least for several years now, into the home. But now with this audio only service, I think that'll expand the access even further. And then finally, I think the licensure changes that we've made, so that now if the state says you can be licensed out of state and will still allow you to provide telehealth during the crisis, I think that will expand access to services, especially for our beneficiaries in rural areas where there may not be a lot of local providers, but a provider from out of state can now help them take care of their family and ensure they get the care that they need.
And as you've been rolling these out, is there any consideration of maintaining these capabilities once we get beyond the pandemic?
Yes, there is. We are certainly actively looking at what is the impact of these changes. How do they impact access? How do they impact the outcomes for our families? And for those that are effective, we are certainly going to give strong consideration to continuing them over the long term.
Great, thank you very much. Kathy, any more questions coming in from the audience?
We do. We have a lot. Here's one. Given the financial strain on the civilian healthcare system, do you have concerns about the viability of the network? What steps are you taking to ensure the TRICARE network remains robust?
So, great question. Obviously, we know and we've seen in the media and elsewhere that healthcare systems are being challenged financially in some cases. At this point, our networks are still very robust. We are still able to maintain our access to care standards. We're watching that very closely. I think by expanding telehealth, that both improves access for our families, but also, allows our providers, the opportunity to continue to see patients, continue to be viable, as you said. So we are working very closely with our provider community, with our managed care support contractors to make sure we continue to have robust networks and that our patients have access to the care that they need.
Can I add something for the direct care system? Telehealth is one of my newest areas that I'm working on. We've learned so much during this pandemic. We've had a 10-week pilot worldwide on the use of telehealth and found there's just so many great things that we could do. There's very few health systems globally like we are. And so that means we're uniquely able to leverage those skills for telehealth. So in many cases, we do have, I'm retired Air Force, so we have small Air Force bases out in the middle of boondocks, as we like to say, so people don't complain about the jet sounds. When that happens, maybe there isn't a robust network there, no matter how hard our managed care support contractors try to develop one. And we're seeing now we can bring telehealth to the patient. If we can do it from 10 miles away, we can do it from 10,000 miles away. So that's why we're going to be working very closely with the network to supplement and support our patients with both our direct and purchase care system working together.
Great, thank you very much. Colonel Gamelin, I'd like to get you engaged in the conversation as well. Could you comment a little bit about what families need to know about accessing medications, whether it's through the MTF or through mail order or the retail pharmacy?
Yeah, hi, good afternoon, everybody. Apologies, I'm not on video, having some technical difficulties, so audio only. Of our 9.5 million beneficiaries, 7.1 million of our patients actually use pharmacy services. So I know pharmacy tends to be very foremost on people's minds, especially as we go through this COVID pandemic. And so, kind of the things that I think are most important to people are the questions of, can I still get my medications? And do I still have access to pharmacies? And so I'd like to just kind of address those 2 points real quick. So when it comes to the pharmacy supply chain, it is actually very robust. I've been part of a number of task forces working with FEMA, with Defense Logistics Agency, and with Health and Human Services, just looking at the pharmaceutical supply chain. And despite concerns about shortages, we actually do have a very robust supply chain for pharmaceuticals. There are no long-term outages forecast, and companies are actually working very hard to increase production. As you can imagine, turning out more pharmaceuticals overnight is somewhat difficult to do, and so it takes a little period of time for them to get ramped up. The one area where we have seen an issue, and that was with 2 drugs, just because there was such a shift in demand for the 2 of them. And I'd like to address that real quick. So we have quantity limits for 3 groups of medications. The first one, if you are familiar with hydroxychloroquine, initially there was some interest that it may help, kind of reduce the severity of the disease. And so we saw a dramatic, it was about a 10-fold increase in demand for hydroxychloroquine. Well, hydroxychloroquine is mainly used for lupus and for rheumatoid arthritis. And so there's FDA indications for that. And predominantly our folks use it for those indications. Some also use it for malaria prophylaxis or treatment of a malaria case. But with that dramatic increase, we had to put some quantity limits into place to ensure that the people that truly needed it, the ones that were getting it for lupus or rheumatoid arthritis, still had access to it. And so unfortunately, we had to put in a temporary quantity limit. We are actually going to have a conversation again within 2 weeks with our prime vendors and with industry. And if we feel that the supply is coming at us the way we need it, then we will pull those quantity limits off. The other one where there was significant shift was for albuterol inhalers and levoalbuterol inhalers. And so what changed there was a tremendous increase in demand in hospitals. Usually hospitals, when somebody needs a breathing treatment, they use nebulizers. But what they found was because COVID is you don't want to have aerosolized viral particles being blown out of these little tubes in rooms. Hospitals all switched to these multi-dose inhalers. So as you can imagine, the supply dropped off very quickly. Now, what we're seeing now is a considerable leveling off of the demand signal. And again, the supply signal remains very strong. Our manufacturers have assured us they are producing to higher levels than previous. And we are working with our national prime vendors, both AmerisourceBergen as well as McKesson, who does all of the resupply for the mail order point of service. And we are pretty confident that within 2 weeks, we should be able to pull the quantity limits off and go back to just normal fill rates on those medications. But again, overall supply chain, we do not see any issues down the road. When it comes to pharmacy access, of course, we've got the 3 points of service. The U.S. has 66,000 retail pharmacies, and the TRICARE network has 56,000 pharmacies in it. So it's a very robust offering. And now, certainly, I think the downside with both the retail and with the mail order point of service is the congressionally mandated copay for those points of service. But it is very much a large network. We have not seen any degradation whatsoever with the COVID. And, in fact, a lot of retail pharmacies already have drive-throughs, and a lot of them offer actual home delivery where, you order it. And if you live in the neighborhood there, they will drop it off to you. So those that are concerned about having to go into an MTF pharmacy, it's a great option. Mail order is also very robust. Express Scripts has 3 primary sites that they operate out of to do fulfillment and mailing. And so even if one area were to, say, have some degradation due to, staff illness, they would still be able to fulfill all the rest of that demand from those other locations. The third point of service, of course, is the military treatment facilities. So across the world, we have almost 700 MTF pharmacies. And of that, right now, we only have one that is fully closed. And that is the Naval Branch Health Clinic Northwest, down in the Portsmouth area. That one closed primarily due to the deployment of the Comfort. Most of the staff was deployed up to New York to help with COVID response. They are in the mandatory kind of quarantine period post their mission, but hopefully we will hear about them opening back up soon. So out of 700 to only have one closed right now is I think pretty good. We do have 6 locations that have some limits. Edwards, Moody, Beale, McGuire-Dix, Cannon, and Shaw. Those are primarily Air Force bases. And the restrictions that they have right now are they're still seeing all beneficiaries, but they have certain days where they are seeing retirees. So they have some limited access to the bases. And then there's only 2 locations, Nellis Air Force Base and Goodfellow Air Force Base, that have actually tried to have their retirees and retired family members pick either retail or mail while they go through the pandemic. And then as soon as they can return back to normal operations, those patients can certainly come back in. That said, there's certainly been challenges. Usually most MTF pharmacies are located within the clinics. And so having single points of access into facilities, trying to keep the waiting rooms to a minimum. I think the pharmacies have done a very good job in helping out patients by providing alternate pickup locations, and a lot of them have done very well with the curbside service where the patients show up and they have the runners go back and forth between the building and the cars and provide patients with their pharmaceuticals. So I think that's just a quick overview, and I'm sure we'll have plenty of questions.
Yeah, in fact, we do. I think Kathy's got some questions that have come in from the audience.
Yes,
Okay.
Colonel Gamlin, a couple. Here's a quick one. Can a prescription that normally requires a signature when picked up at MTF be changed to Express Scripts?
So absolutely. I think what we've encouraged, the MTFs to do is to really try to advertise mail order. That is, for a maintenance medication, which is something that you take on an ongoing basis. It's relatively simple. Where you would call you could call Express Scripts or you could call the pharmacy, and they will transfer that prescription to mail for you. I think if you've never used it before, usually they can get the mailed out to you very, very quickly. The registration is very minimal, and we've had great success at a lot of locations, especially Nellis, where they did have to kind of, due to a public health emergency, really curtail services to beneficiaries. They worked effectively with ESI to kind of do a lot of transfers over to that point of service.
Thank you. And will the military treatment facilities or the pharmacies be covering antibody testing in the future for either military members or family members?
It's a good question. And I think when we look at sort of the realm of testing and then also eventually vaccines, certainly a lot of network pharmacies, especially Walgreens, they do a pretty good job of providing immunizations for our beneficiaries at that point of service. We don't have an end state yet. I think once we kind of get more information on COVID itself, how it's evolving, how we test for it, I think that, if we have some opportunities where we can spread some of that testing out across not just the clinics, but also have some pharmacy involvement, I think pharmacy is certainly more than capable to help provide some of those services.
Terrific. Ash, back to you.
Yeah, thank you, and thanks for that, Colonel Gamaliel. Captain Simmer, just get back to you. In addition to serving as the Chief Medical Officer, you're also a psychiatrist. And one of the concerns of families, and not just military families, but all families, is the impact the pandemic is having on mental health and well-being. We've seen through the Pain Point survey that 75% of respondents are taking measures to support their own mental health. What's DHA doing to ensure access to resources or to promote the mental health of beneficiaries?
Absolutely, and a great question. And I was very pleased to see that, the 75%. I think that's very good. We're doing a number of things, both in terms of providing actual mental health care and also then non-clinical mental health type services. So obviously, we cover mental health services, individual therapy, group therapy, medication management is needed through the telehealth benefit. We pay for telehealth the same. We would pay for an in-person visit to encourage people to use it. And as I mentioned, we are now eliminating the co-pays and cost shares for those telehealth visits for the duration of the crisis. So I think that'll improve access to care. We're also very focused on making sure that services are available. So we have now added intensive outpatient services as a covered benefit for the duration of the crisis by telehealth. That's something we had not done in the past. But for folks who need that level of service, that's available. We've also, as I mentioned, added the family guidance and training under the applied behavior analysis for children with autism. So we've tried to add a number of things to ensure families can maintain and improve their mental health. But I think there's a number of things beyond clinical services. We're partnering very closely with things like military chaplains, like Military One Source, military family life counselors, all of which extend our ability to take care of our beneficiaries, make sure that our beneficiaries get the support and care that they need. You can go to our website, tricare.mil. On the very front page there's a link you can click on that gives you a number of ways to manage and effectively work as a family through this crisis and support your family. So I think we're trying to do a number of different things to ensure families have access to services they need and resources so that, as much as this is a challenge, it can also be an opportunity to grow.
Great. Thank you for that, Captain Simmer. Kathy, I think we've got some more questions coming in from the audiences.
Yes, here's a couple specifically about retirees. Both how do these comments affect coverage for retirees, and what if a retiree had to leave the base clinic because they're open only to active duty families, yet they find the community physician offices are overfilled? Do you have a response for those situations?
Let me start with that particular case for the direct care system. In the example of Nellis, for example, they're only taking care of, I think, residents who are living on base or were for a while. Cannon Air Force Base, a special operations base, very similar, but they continued providing care to the retirees via virtual care. So the patients, just like always, could send a secure message, or they could call the appointment line and be scheduled for a virtual appointment with their provider. If their provider felt they needed to be seen in person, coming on the installation because of installation rules, not medical treatment facility rules, then our MTFs providers would arrange for them to receive care in the network. But what we're finding is that for really care that is medically necessary, that which cannot be safely delayed. So it has to be done. There's very little, at least in primary care, that our providers haven't been able to address, and that includes chronic complex disease, comorbidly presented in the same patient with, for example, diabetes and hypertension and depression. We do that in clinic, and we're able to find that we're very effectively able to do it, our providers say, over the phone. So just because our retirees were impaneled to our military treatment facilities couldn't get in our medical treatment, we still have been able to care for them.
If I could jump in there too, I think we've worked very hard to make sure that our networks are robust and able to provide the care that people need. Telehealth has helped with that because, especially now that you can do it across state lines. With telehealth, we can provide services even if someone's in a rural area. We can get them specialty care that doesn't require hands-on care. And I think that expansion has helped us very much. In the past month, it was actually the most number of telehealth visits we've ever had in TRICARE. And I think that's a good example that we're able to provide the access people need, maybe not quite the way we used to. But I think what we're learning here is that in the future, there are going to be some new ways that we can provide access to care and make sure people get the care they need, often from the comfort of their own home.
Yeah, I think Ash and I have both found that this has been popular for a lot of families to have this opportunity to have increased access to telehealth. Here's one where telehealth is a little more difficult. What are your prognostications for occupational therapy and physical therapy? For people who have those needs, what do we see in the future?
So those are also on the table. We hold webinars out of my office with all MTFs worldwide for the last year and a half. And then we have a very active military health system specific Facebook page, and we're sharing those best practices. And so several different medical treatment facilities shared their occupational and physical therapy on film. They made recordings and then provided us what we call our standard operating procedures on how to do those patient visits. And those have been extremely popular. And imagine in the future, an active duty troop who's maybe out in the desert, and we don't want to lose that soldier, sailor, airman, or Marine to a long drive back to the medical treatment facility. We're realizing we can do those very important types of care that we used to think we could only do in person over camera by, let's watch me do this exercise. So we have high hopes for that and many other specialties.
So just to follow up, if a person has not been seeking out to schedule their occupational therapy or physical therapy appointment because of COVID, perhaps they should reach out and see if there's a virtual therapy opportunity?
Yes, again, this is something we're just learning as we go. So Laughlin Air Force Base might not have it, but they might have it at San Diego. But it is our hope to capture all these best practices rapidly. So by this time next year, we've really taken leaps and bounds forward in how we can provide care.
Perfect.
Ms. Julian, if I could just follow up, earlier in your comments, you had mentioned that right now only about half of the appointments are being filled, but that you think that they're also, people are deferring elective care, those sorts of things. What are you doing to prepare for the potential surge, right, in that demand once the MTFs open up, those sorts of things, once elective care is no longer being deferred?
So that's a great question, because as someone once told me, your first step to planning to post-pandemic should be the day the pandemic started. We are a little behind that, but now we've caught up. So yesterday, our Assistant Director for Healthcare Administration, who works for General Place, she issued guidance out of our office that told them to get their appointment, the MTFs, to get their appointment templates ready. So I can't see a patient if I can't schedule a patient into an appointment. Soon after that, we'll release, it's already written and signed, our plan to resume a transition phase in approach to full operation. So we're looking at those patients that are like maybe the highest acuity, or as we call them, have the most serious health conditions. And we're going to be reaching out and asking them to come in and assuring them we're going to take them. We're going to have longer appointments because we know that perhaps they haven't been seen for 4 or 5 months. And we're going to plan ahead and say, well, you need a mammogram. It looks like a colonoscopy, and let's get all these medications refilled. What problems do you have? To try to do as much as we can while people are still a little afraid to come in on that very first visit. We think by doing that and reaching out proactively, having our patients come in and meet as many of their needs as possible on that visit, we can prevent a huge demand surge. I think what we're also learning is a lot of the things that patients would come in for us, and it may sound silly, but it happens. People get afraid. Maybe they sneezed and they think that I'm getting a cold, and an hour later they were seeking an appointment. And now maybe they're realizing those things don't need to be seen. But for those things, and there are many of them, we want to lay eyes on our patients. So we're planning to bring them in. And this is in both primary and specialty care.
One additional question there. You know, as there's been a lot of discussion, you know, anyone paying attention to the news is thinking about, you know, this kind of phased approach to reopening. What sorts of conditions need to be met in order to reopen some of those clinics? You know, how can you help to manage the expectations of families of when they should start thinking about, now it's a time to start maybe scheduling some of those appointments?
So first of all, you can call anytime, and the appointment desk people will know when it is that we can bring you in. But again, there's a lot we can do virtually. So I would urge patients not to hesitate to call us if they have a question. There are no dumb questions. There are only appointment clerks ready to put you together with a provider virtually if necessary. So it's all going to be local. And we know that the pandemic strikes at different times. And I used a Cannon Air Force Base as an example. That installation, it's a special operation. Those places go into lockdown. It has nothing to do with medical. It has everything to do with their special operations management. So all of it will be local, but some of the conditions are what we call the health protection condition, which is set by the base. So in other words, what's the state of the pandemic? What is the number, what are some of the conditions you've seen come out of the Office of the President, which is 14 days without a increase in positive cases or hospitalizations. So at that point, we also look at the Centers for Medicare and Medicaid guidelines and the guidelines from the Centers for Disease Control. But again, that's not for our patients to have to figure out all the different public health rules of engagement. Just go ahead and give us a call, and we will be up to date, and we'll give you an expectation. And remember, secure messaging, it's asynchronous. You can always send us a secure message and we'll respond.
That's great. Thank you very much. Kathy, any more questions coming in from the audience?
Yeah, here's a great one. Is there a cheat sheet on COVID-19 symptoms and recommendations and healthcare resources available for military family members?
Yes, if you go to tricare.mil, all the major symptoms are updated as they are updated by the Centers for Disease Control. So, you know, some of the most recent ones were the shaking or the pink eye and the loss of taste. Those are all there. But also, we recently got a self-checker tool developed by the Department of Defense, which we're loading hopefully today on tricare.mil. And I've taken it several times and just put in different, it's totally private, nobody gets the results, but it gives you recommendations on what you should do depending on whatever your symptoms show. And it's targeted for us. It asks if you're active duty, GS contractor, family member. And so on there, it will also have the specific guidance from my office on, like I said, call your appointment desk, call our nurse advice line, send a secure message, call the appointment line. We try to make sure there's multiple ways that you can seek care in the direct care system. So we're really pleased by that new symptom checker. It's, I thought it was fun to do it myself. It's really fast and easy.
Wonderful.
I know we're drawing near to the end of our time, and this has been really very informative. I have one final question for each of you, and if you just maybe take a few moments, if you think ahead about how we continue to live with COVID-19, right? Because I think we're going to live with this for a little while, certainly until there's a vaccine. What's keeping you up at night? What are you thinking about as you think ahead? Captain Simmer, can we start with you?
Sure. I think there's a couple of things. One is, I think, we've started to see some progress. We've seen areas reopen a bit, seen the number of cases start to decline, at least in some parts of the country. I'm certainly worried about, well, what happens if there's a second wave, as many people seem to think is likely? And how do we manage that? And how do we make sure that we still have the resources in place to manage that? I think the second thing that concerns me is what are the long-term effects, both physical and psychological? I think this will lead to long-term changes in how we have to live, how we interact, at least until there's a vaccine. And so I think a key part of this is helping folks manage the stress of being in this changed environment. And how do we make sure that families continue to thrive and grow and give them the resources they need to make sure that even with the changes, they can still find the positives. And I think that's a key part of what we need to do is help our families keep moving forward.
Thank you. Ms. Julian?
I have two. One is for us in the military health system. A lot of times we're really great at going to war, and then we don't learn at what we've what's happened to us. So my job is to capture all the great things that we did that we never thought were possible. Drive up pharmacies, the way we can provide virtual care to our patients after hours in their own home, which we found leads to patient engagement. We just want to revert back to the status quo because it's easy and they know it. So my job is to keep the pressure on, working with our leaders and our NPS to not forget and really see if there's a silver lining to any patient who is harmed in this. To honor them would be to learn from all the great things that have happened and how we can provide better, more patient-centered care. For our patients, the thing that keeps me up at night, and I know it does Admiral Riggs, is delaying something longer than it needs to be and leading to a poor outcome. But again, I'm going to foot stomp again. I like to repeat myself, and that is, please give us a call. Don't think it's too dumb. Don't think that we're going to be mad. We'll answer any question, but we would rather be safe than sorry. So we want to address things early and often as we need to, so that you have the best healthcare outcome.
Great, thank you. And from what you said before, there's capacity there, right? So people ought to make the call now rather than wait till later.
Yes, absolutely. And again, I want to temper expectations. We may need to do it virtually. And if the provider feels that he or she can do that and the conditions are such that it's safe for you or safer for other patients that could be exposed to you, because no one really knows. You could be asymptomatic and shedding virus. We're going to ask that you can do it virtually. But if there's not a provider in our system who can go and say, I just talked to someone on the phone and I need to bring them in, we'll bring.
Great, thank you very much. Colonel Gmelin, what keeps you up?
I think kind of along the lines of what Captain Simmer and Ms. Julian have mentioned is, to me, it's about outcomes. The reason people take pharmaceuticals is because they have some sort of a condition and they need to get better. We want to improve their overall health. And what we've seen during this COVID pandemic is obviously a big decrease in, people seeking healthcare. Whether it was just because their resources are closed or have limited operations, elective things have been put off. I think a lot of folks, rightly so, are somewhat worried. I mean, the ones that are at higher risk are patients that are a little bit older, that have comorbid disease states, and they're looking to kind of shelter in place and stay at home. And so we've seen a pretty significant decrease in pharmacy volume across all points of service except mail. Mail has stayed constant, which makes sense because you order it online and it gets sent to your house. So I think it's, that's the safest point of service. But we've seen a 30+% decrease in pharmacy utilization in retail and at the MTFs. Some of that certainly is attributed to less appointments available, and so there are some less pharmaceuticals. But I think what worries me is if we have patients who truly have a significant medical condition, and we're talking about arrhythmias, heart conditions, seizure disorders, something that is relatively significant, or have they now given up taking medications and really try to opt for, they feel that they are safer staying at home, vice trying to get these medications that they really, really need. And so, the question would then be, we need to evaluate what's happened and try to figure out, why people exhibited the behaviors that they did. And then how do we better meet those patients' needs going forward? Nobody should ever be in fear, of not treating themselves because of something else. And so it's how do we provide them the pharmaceutical services that they need for their condition so they don't have to worry about it. So I think that's probably one of the biggest ones that's been on my mind during this whole time.
Great. Well, thank you for sharing that. And I want to thank Captain Simmer, Ms. Julian, Colonel Gmelin. I really want to thank you for spending some time with us and answering questions, not only from us, but from the audience. And most importantly, I want to thank you and your colleagues at the Defense Health Agency for what you do to take care of military families. Thanks for all you're doing. Kathy, I'll turn back to you.
Yep, it's Now my privilege to wrap up. Thank you, Ash, and your team at NMFA for organizing this terrific panel. Thank you to our panelists. It means so much, all of the hard work you're doing to take care of our families during this pandemic. We really appreciate your responsiveness on this town hall. All of us in our larger collaborative are working to try to make sure we're taking care of military families during this time, and particularly making sure everyone has the healthcare access that they need. Thank you to Colonel Silverman for being with us, providing such great information at the top, and of course to you, Captain Zimmer, Ms. Julian, and Colonel Gamellan. We're so grateful to you all. I'd like to remind everyone attending today to please check your email after this town hall. We'll give you follow-up on this discussion, links to important resources that have been mentioned, and we'll ask for your input on a survey to help us do a better job in the future and to determine future topics. We'll also be giving you a link to the pain points poll. People are paying great attention to that poll, so we ask those of you on this call who are service members, veterans, or family members to please take that poll so we can continue to inform nonprofits and government officials, service providers. Please join us Thursday, May 14th at 3 p.m. for a town hall addressing the needs of veterans during COVID-19. This will be focusing on veterans benefits with opening remarks by Ms. Margarita Devlin, the Principal Deputy Undersecretary of Benefits in the Department of Veterans Affairs. We'll be having a conversation after that with the Wounded Warrior Project, American Legion, and the VFW. In the meantime, please check out our website, COVID-19 Military Support, which is full of information and resources to help you and your families. Thank you again for joining us today, and I hope to see you on a future gathering. All best.